Good evening, everyone. It is a pleasure to welcome you all to Georgetown to our annual Maloy Family Distinguished Lecture. The Maloy Distinguished Lecture is a special evening hosted nearly every year for the past 16 years by the Science, Technology, and International Affairs, or STIA program, in the Edmund A. Walsh School of Foreign Service. It is a true privilege to welcome Dr. Sarah Bennett this year to be our distinguished lecturer. Dr. Bennett joins an impressive list of Maloy Distinguished Lecturers, which we have listed on the back of the program. And last year we hosted Dr. Akin Abouyami, a leader in cities, infection, and security. 2 years ago, we hosted Dr. Helene Gale, a leader in global health development. 3 years ago, we hosted Dr. Vikram Patel, a true visionary who has transformed the movement for global mental health. The year before, we hosted the editor-in-chief of the medical journal The Lancet, Sir Richard Horton. These enriching lectures have been made possible by the generosity and the vision of Paul and Catherine Maloy. In 1999, Paul and Catherine Maloy endowed the Maloy Family Fund to support health-related projects, and we have some of the Maloy family with us today, so thank you so much. And they specifically gave this to the STIA program so we could support a lecture every year. And these initiatives focus on international health issues, benefiting students from both the School of Foreign Service and the School of Nursing and Health Studies. Paul J. Maloy is a 1968 graduate of the School of Foreign Service, and Catherine Fuller Maloy is a 1968 graduate of the School of Nursing and Health Studies. Both have been active in Georgetown alumni relations for many years. This year, we welcome Dr. Sarah Bennett as the Maloy Distinguished Lecturer, who brings health systems thinking to the center of her global health work. With a background in politics and economics, training in health financing fueled her broad interests in health systems. Her work with the private sector, health worker motivations, changing roles of government, and the impact of global health initiatives on health systems bring together a deep and comprehensive understanding of the complexities facing health systems around the world. In addition to her extensive publications, Dr. Bennett has consulted on projects for the World Bank, DFID, USAID, and UNICEF, and for 2 years was the director of the Alliance for Health Policy and Systems Research at the World Health Organization. Currently, she serves as the director of the DRPH program at Johns Hopkins University Bloomberg School of Public Health. This program is cross-cutting across the school and focused on enhancing practitioners in global health from around the world. Her current research and programmatic work addresses some of the institutional challenges in promoting stronger governance for health. She also serves as the CEO of the Future Health Systems Consortium and former chair of Health Systems Global and chair of the Joint Health Systems Research Committee. And I have to say, the last meeting that she was part of hosting in September in Liverpool was one of the most inclusive global meetings I have ever attended, and it was truly a privilege, as is today. Thank you for coming. Dr. Sarah Bennett.
Thank you very much, Emily. And thank you all. It's a real pleasure to be here, and I'd like to start out by thanking in particular the Maloy family for this opportunity. I think it's a fantastic opportunity to bring together a diverse community within Georgetown. And I was really hoping that we might be able to have a few of our Johns Hopkins students come up and join me today. We have one, so welcome to James, and I hope that you'll make him feel at home afterwards. But it seems a little bit ironic that, these two universities are so close together and have quite a lot of overlapping interests, but I'm not sure how often we get the chance to really engage with each other. So my talk today is about the future of global health. And in many senses, it's a very personal talk. I mean, Emily provided an introduction which talked about my work within health systems, health financing, health workforce. But this talk is a little bit different because I think it's really my attempt to try and make sense of professional environment in which I've, if you will, sort of grown up, lived in, and have spent, the past 30 years or so working within this space. And I guess that I wouldn't have chosen to talk about this topic, the future of global health, if I hadn't felt that we were at an inflection point or a turning point in global health. and perhaps more broadly in the way that we think about international development. And I know that this audience is likely to have people who are not just interested in global health, but more international development more broadly. So I would really welcome your views about your reactions to that. So I was born a little while after the events on this slide, which depict obviously the Bretton Woods Agreement on the left. I think that's Maynard Keynes in the middle there, talking with others. And these was obviously the agreement in 1944 that established the Bretton Woods institutions, the World Bank and the IMF. And then on the right-hand side, you can see the WHO, which was established in 1948. And I don't want to put too rosy a lens on the role that these institutions have had in terms of global health and international development. But I do think that their existence and their creation have sort of coincided with a period in which we've been very fortunate to have peace and stability by and large, and also, and reflected, I think, in this quotation from Fred Vinson, who was the US Secretary of the Treasury at the time, I think there was also an unusual ambition about what could be achieved through international cooperation, as this quote suggests, a bedrock of genuine international cooperation. So this is sort of going back, obviously, quite a long while, but I'm putting it out there because I think it's the backdrop to what the more immediate effects that I have seen within global health. And many of you may be familiar with this chart from the International Health Metrics and Evaluation, the Institute for Health Metrics and Evaluation in Washington, which shows clearly the very, very rapid growth in development assistance for health, particularly over the years about 2002 through to about 2010, 2012. I think that as a health systems researcher in the early 2000s, one of the things that I was really interested in understanding was how was this really massive influx in some countries. I mean, I think that if you looked at countries like Botswana, Lesotho at this time, their aid was often sort of quadrupling even more because of the very large investments that were being made in HIV/AIDS. So at this time in the early 2000s, one of the things that I was interested to explore was how does this affect health systems? Does this mass influx of funding actually strengthen health systems and enable the countries to better achieve on their own health goals? Or are there problems of distortion that this very large influx of money can create? But as you can see, from about 2010, 2011, 2012 onwards, we've seen a stagnation in terms of development assistance for health. HIV funding has actually declined somewhat, and to be very clear that this period of growth from about 2002 to 2012, I think that it's fair to say that HIV/AIDS was really at the forefront of that. This was the period when we had the creation of the Global Fund to fight AIDS, TB, and malaria, and PEPFAR, two of the sort of really mammoth global health initiatives, which I think have changed the face of global health in many regards. So more recently, I think HIV/AIDS funding has stagnated. And we've seen some modest increases around funding for maternal, neonatal, and child health, and also some funding which is categorized here as other, but I think a lot of this is actually going to refugees and humanitarian health. And I find somewhat ironically that the research that I was doing in the early 2000s to understand, well, what's the effects of this massive influx of aid on health systems, I'm now almost doing the reverse, sort of looking at some of the processes of transition as what happens as donors pull out their support from countries. So Barack Obama said, foreign assistance is not an end in itself. The purpose of aid must be to create the conditions where it's no longer needed. Now, I wouldn't argue that we've got to the point where we have done ourselves out of a job. I think that's far from the case, and aid is no longer needed. But I do think that there are currently tectonic shifts going on in the global political and economic environment, which mean that we need to revisit how we conceive of global health and our role within it. And when I talk about our role, I mean, I guess I'm sort of assuming that most of the audience in the room are educators, researchers, and students. And so the kind of perspective that I'm coming from is that broad perspective, and the kind of questions that I'm really interested in addressing, and I guess sort of struggling myself to find good answers to. How should we be preparing students interested in global health for success in careers that might extend over the next 40 to 50 years? Or how do we position our own organizations for success in such a rapidly changing global health landscape? And I'm going to talk more about how that global health landscape is changing. And then linked to these questions, I think I am also sort of seeking answers about how do we address the moral and ethical dilemmas that I think we're going to need to navigate while supporting the kind of organizational change in our universities, in our non-governmental organizations that are going to be needed. So my talk is really going to touch upon three different pillars, if you will. Firstly, around economic development, trade, and inequality. Secondly, about trends in development assistance, particularly development assistance for health. And thirdly, around higher education and global health. And based upon those three broad pillars, I then want to spend some time at the end talking a little bit about, well, what are the implications of what I have said? Where do we go from here? So in terms of economic development and trade, the past 30 years, as many of you will realize, have seen many millions of people who've been lifted out of poverty. And this slide from the World Bank just gives you a snapshot of, in many ways, the very impressive achievements in this regard. And across all of the nation, all of the different regions, I think we see far less proportion, far fewer, a much lower proportion of people in poverty. However, and some of you may be familiar with this rather famous chart developed by Branko Milanovic, which is for obvious reasons known as the elephant trunk chart. It shows how people distributed across the range of global income distributions have benefited from growth, in this case between the period 1998 and 2008. So at the very bottom on the left-hand side here, we can see the poorest who've been essentially locked out of growth, sometimes referred to as by Paul Collier as the bottom billion. And that often we think that the challenges that these particular parts of our community have faced are due to conflict, natural resources curse, poor governance, and being landlocked. So countries like people living in countries such as Afghanistan, Chad, Djibouti, Somalia, maybe face this particular part of the distribution. But then for many countries which were low-income countries or lower middle-income countries back in the late 1990s, we've seen rapid rising in incomes, particularly in the emerging economies and particularly in China. And then at the bottom of the trunk, if you will, we see the decline of the developed world and middle class. And I think that this has led to, obviously, a sort of crisis in many Western societies, and building upon that, more conservative politics, a retreat from global engagement, and perhaps dwindling support for aid and for development assistance. And then on the far right, of course, the booming global elite, that small fraction of the global population who are at the sort of top of the income distribution and have been benefited again from globalization. So the World Inequality Report also talks about US income inequality, and I'm sure that many of you have seen this before, but the report also notes that there has been growth in income inequality in almost every region of the world. So this just shows what's happened to the top 1% of the US population in terms of the share of the economy that they have compared to the bottom 50%. And really a very striking picture here in terms of the inequitable distribution of income within the US. But I think it's perhaps more surprising when we start looking across other countries and see, for example, the historical trends in terms of income distribution in India. that these charts are not strictly comparable. This India chart is talking about the top 10%, not the top 1%, and comparing it with the bottom 40%. But still, nonetheless, you can see somewhat similar patterns in terms of what's going on, with the wealthier becoming even wealthier, and often the people at the bottom of the income distribution receiving less. So what does this mean for our health systems? I was reading a draft manuscript by a former doctoral student of mine, Venus Sriram, and she was exploring the development of emergency medicine and thinking about the development of emergency medicine in India. And I was struck by this quotation that she had in her manuscript. And it's from an informant in India who was saying, there was an international effect. If Singapore was having emergency medicine, and then why shouldn't India have emergency medicine too? And at first I couldn't understand why someone in India, a huge country with a GDP per capita of about $1,700, would be comparing themselves to Singapore, which is almost at the other end of the spectrum, a tiny, tiny country which is the third richest country in the world. And then I was sort of reflecting further on this, and I thought, well, there are parts of India that look like Singapore. This is a photograph of a development in Gurgaon, just outside of Delhi. And then there are parts of India that look a lot more like this. So I think that when I started work in this field, it was very easy for us to talk about rich countries and poor countries, the developed world and the developing world. But I do feel that those boundaries, those distinctions that we used to make really no longer work for us. We have immensely rich countries with very significant numbers of poor people living within them, and obviously also very poor countries which have significant numbers of extremely rich people living in them. And this is a topic that I want to return to later in the talk. So the next domain of interest that I wanted to talk about, and there's actually quite a substantial amount of material around this, is really trying to understand some of the shifts and trends that we've seen within development assistance for health. And so as a Brit, I have been appalled, I guess, over the past couple of years to see the situation in the UK and the kind of debates and decisions that Brexit has led to. And I think that there's also a very rapidly changing aid landscape where we're seeing a withdrawal in some regards from global engagement by some high-income countries and the UK, in terms of the US and the UK, driven at least in part by some of the frustrations that I spoke about earlier of those who have lost out through globalization in these high-income countries. And we're seeing this play out in different ways in terms of aid budgets. I know that Trump's initial efforts to reduce development spending in the US have been resisted to a considerable degree. But obviously this is an ongoing challenge, I think, in terms of being able to support aid budgets. And I personally just find it quite difficult to envisage how high-income countries are going to be able to maintain consensus about the current levels of development assistance, especially when there is clearly such wealth in some of the countries that we're providing aid to. And reflecting on the UK and some of the others, particularly the Scandinavian countries, which have sought to achieve 0.7% of GNP going to development assistance. The UK government, very surprisingly, I think, has defended that in the face of cuts really across health, education, and security within the UK. And I think that there's also a growing narrative, a negative narrative about aid, as the recent Oxfam scandal in the UK reflected. This is a snippet from one of the papers in the UK, which is featuring Priti Patel, the former Minister for Development Assistance at the Department for International Development. And I'm not sure if you can read the text here, but she's saying sex abusers are rife in the aid sector. So there's a lot of talk about the challenges that we have in terms of keeping development assistance entities operating appropriately. And I think that the recent scandals at UNAIDS are also further undermining people's belief, unfortunately, in the good that development assistance for health can do. And then, of course, more recently, I put up this picture because it describes, pointing the arsonist to look after the institution. And this is a photograph of Malpass, who was nominated yesterday as the new head of the World Bank. On the other side of the coin, I think that there are a number of middle-income countries who are now questioning whether they need aid. This is one of my favorite quotes from Mukherjee, who is a former Indian finance minister. He's reflecting actually on aid from the UK. He says, "We do not require the aid. It is a peanut in our total development exercise." And you can imagine the kind of field day that the British press had with this. And this is the Daily Telegraph, a conservative-leaning paper, saying Pranab Mukherjee and other Indian ministers tried to terminate Britain's aid to their booming country last year, but relented after the British begged them to keep taking the money. So beyond these political dynamics that are playing out, I think that there's also a much more thoughtful debate about donor transitions and what's happening to aid. And the slide just seeks to try and identify some of those factors which are at play. I think that increasingly we recognize that external funds and technical know-how are limited, and perhaps it makes most sense to focus them on the poorest countries and those with the most constrained technical and managerial capacity. And also, I think more and more, and I'll come back to this theme again, we're seeing that middle-income countries have increasing technical capability and financial capability, and they're really ready to transition off development assistance. And there's also a thought, and I think that there's a good sense to this, that countries that do take over running their own programs and take responsibility for technical, managerial, and financial responsibility are more likely to run efficient and sustainable health programs. So I guess the question, and I'm thinking about this in the context of global health, is really, where is development assistance for global health going? What are we likely to see as the trends over the next 10 to 15 years? And I'm going to talk about three broad areas which I see developing. Firstly, around what I'm calling the securitization of aid. Secondly, about the links between aid and trade and the use of aid to promote trade. And thirdly, around the diversification of funding sources in terms of new bilateral donors and private sector sponsorship. So firstly, on the securitization question, we're obviously living in an increasingly unstable world with sudden and unpredictable threats, whether those are from ISIS or Zika. And these are largely due to globalization and the speed with which people, ideas, and viruses travel. So despite the proposed CDC cuts to Global Health Security Initiative, I really don't see this type of spending going away. And the National Academies of Science agree with me. In a recent report on the future of global health, they put health security front and center. And I think that richer countries will continue to invest in areas they perceive are needed to protect themselves, whether this is supporting third countries to host refugees or whether it's building disease outbreak capacity in low-income countries. The second area that I wanted to talk a little bit about was around aid to promote trade. I think we've seen a recent trend of the absorption of aid departments into departments of foreign affairs and trade. So, for example, in Australia, Canada, and Iceland, what used to be standalone departments for international assistance or for development assistance have all now been subsumed into foreign affairs departments or something similar, foreign affairs and trade often. And even for donors such as DFID that have not been absorbed, we have seen a much greater effort to link their development assistance and trade programs. So, for example, the Newton Fund, which is a new fund in the UK, which is really seeking to fund research in health, is a good example of this. It leverages investment from low and middle income countries, which is another trend that I think we will see increasingly. So the UK will invest so long as there is counterpart support, and in this case you can see Prime Minister Theresa May discussing, I think, this fund actually with counterparts in India. So the other thing that I wanted to talk a little bit about was donor diversification. There's obviously a number of new donors on the block, India, Brazil, China, but China is by far and away the biggest new donor. And this map, and I'm not sure how well you can see it, but it shows China's investments in the Belt and Road Initiative. 65 countries overall, and an envisaged $4 to $8 trillion of investment over the entire period of the initiative. And many middle-income countries, as well as low-income countries included in this, Malaysia and Sri Lanka, for example, but also poorer countries such as Ethiopia, Pakistan, and Myanmar. And I think that the development assistance model that China is promoting is very different to that of established donors, really emphasizing infrastructure development and trade, and reflecting a philosophy perhaps more of partnership and cooperation rather than the way that we've traditionally handled aid, which is likely to change the dynamics not just for China and its partners in low and middle income countries, but I think also very much the expectations that those low and middle income countries will have when they start dealing with the more traditional partners. And so health is not a main focus of this kind of initiative, but it's nonetheless quite a significant component. And the health communique on the Belt and Road Initiative articulates the Chinese government's commitments to addressing infectious disease. Notably, they talk about Ebola, SARS, and Zika, and they frame these primarily as risks to trade. But they also talk about maternal and child health services, and they make a strong commitment to healthcare models which China in its own development has pursued, particularly around community health workers and traditional medicine. So while China is clearly unique amongst middle-income countries in terms of the scale of its overseas programs, I think that there are multiple middle-income countries who are starting to use their own funds to directly influence programs abroad, and also they're using their own funds to purchase technical advice, including from overseas partners such as institutions in the US. And in some senses, perhaps they're cutting out the middleman, the development partner, and rather, whether that's an international organization or a bilateral aid agency, and rather saying we want to use our own funds to buy technical assistance directly. So the third theme here that I wanted to talk a little bit about was around the private sector and aid and corporate social responsibility. And I see this as another source of new funding for health. I think that there is evidence that large multinational corporations are increasingly investing in corporate social responsibility overseas as they see this going hand in hand with their efforts to grow markets in low and middle income countries. A few years back, I co-authored a paper actually with an MPH student at Johns Hopkins, which was trying to look at the corporate social responsibility programs of some of the multinational pharmaceutical companies. All of these companies were engaging in differential drug pricing, which really didn't surprise me. I thought that they would be, offering drugs at lower prices in low and middle income countries than they were at home, and they were often sort of seeing that as part of their corporate social responsibility. But I was more surprised at the kind of programs that they were rolling out overseas. So we only looked at 6 different companies, but of those, 5 of them were running mHealth programs, experimenting with the use of mobile health technologies, telephone, etc. Another 5 were working directly with private health practitioners in low and middle income countries, and particularly informal providers. And 4 out of the 6 were providing training to health workers, frequently sort of community-based health workers. And I think that there's really interesting questions here about their motivations in engaging in these kind of corporate social responsibility programs, as they label them. I'm thinking about the work that they were doing with community health workers. I mean, that clearly establishes outlets for the kind of drugs that they're trying to scale up. So in my view, given the complexity of the context in which we operate and the really significant role that some of these private sector actors already play, We cannot afford to ignore the private sector, but there's also very large risks in terms of engaging with them. And I just wanted to reflect on some of those risks more at the global level. So how many of you recognize the gentleman at the top? Yes, Peter Sands. Peter Sands is a British banker with, I would say, relatively little experience in global health, but he was recently appointed as the director of the Global Fund to fight AIDS, TB, and malaria. And the press release from the Global Fund at the time noted his exceptional management and financial experience and an ability to mobilize resources, which I think perhaps gives the game away in terms of why he was seen as a good pick for this post. So shortly after Sands took office, he announced a partnership with Heineken, ostensibly so that Heineken could help the Global Fund to get its commodities out to parts of the world that the Global Fund on its own could not reach. And there was a predictable and, in my view, appropriate backlash against this. And you can see here the launch of this, which I think the picture sort of speaks volumes about some of the challenges here for white male executives from Heineken and Peter Sands. A second example comes from Coca-Cola, and this is taken, the line at the top, directly from the Coca-Cola website about global Coke ads helping in the fight against obesity. And then at the bottom, you have a quotation from their marketing officer, their chief marketing officer, which is talking about Coke's investments to double its business by 2020, with a particular focus on Latino and African American communities in the US, and then developing nations abroad. So Coca-Cola, alongside these efforts to better market its products, is also investing very heavily in health programs. And the snapshot here is taken from in Kenya around the time of the FIFA, the soccer World Cup, where Coca-Cola was trying to associate itself with healthy practices. It was distributing these Coca-Cola branded FIFA soccer balls throughout the villages across Kenya. So I think we have to be wary of the kind of engagement that companies are pursuing as part of their corporate social responsibility activities. I wanted to reflect finally in this section that corporate social responsibility is also increasingly a thing in low and middle income countries. So in 2011, Bill Gates was visiting India. I was there at the time and actually working with the Gates Foundation. And he was putting substantial pressure upon millionaires and billionaires in the Indian context to invest more of their own wealth into social programs within India. And subsequent to this, in 2013, the Indian government, and I'm not sure that these two things are causally connected, but subsequent to this, the Indian government launched its 2013 Companies Act, which required all Indian companies to set aside 2% of their net profits to invest in social programs. And actually, the Act gives quite a prescribed list of activities that would count as social programs, and inevitably including health, as well as sort of various community development activities as part of that. I have not seen this recent act and its stipulations around corporate social responsibility and philanthropy evaluated in any way, and if people have, I would be fascinated to see that. But I have had some experience through approaches that have been made to our group at Hopkins to help with some of the health programs that Indian philanthropists have been putting together. And in a small room and perhaps off record, I would say that there's some of the thinking that has gone into those kind of programs seems to be really quite flawed and problematic. So I foresee overall a shrinking of official aid flows and the multiplication of these kind of initiatives, corporate social responsibility initiatives, but also mixed aid trade programs. And I think that they will raise difficult ethical and practical issues for us about when do we engage, when do we accept funding from these kind of activities for health, and when do we not. So the sort of final substantial segment of my talk before I move on and talk a little bit about the implications is around higher education and global health. And I think that probably everyone in the room is aware of the globalization of higher education and the very rapid growth of international students coming into the US, close to 1 million per annum at the moment, despite all the visa challenges and increasingly internationalization is a core pillar of all of the sort of global elite universities. I know Hopkins currently at my school, we have joint master's programs with the Indian Institute of Health Management Research, joint doctorate in public health programs with institutions in China, and I'm sure that there's many similar initiatives here at Georgetown. So I think that this chart gives you an idea of where those students are coming from, notably from China, from India, and also Nigeria, Indonesia. But it doesn't really show you where they're going to, and I think that that's actually a more interesting angle to this. Unsurprisingly, the US, followed by the UK, and then Australia, are predictably the largest recipients of international student flows. But you may be surprised to hear that Russia and South Africa are already in the top 10, and it's forecast that China, Malaysia, and India will have also entered the top 10 by 2020. So I think we're seeing an emergence of regional centers of excellence across all of the regions of the world. Within the US context, there's clearly been a burgeoning of the field of global health and of the number of institutions hosting global health programs. So this data is taken from the Consortium of Universities and Global Health website. According to their count, the number of comprehensive centers of global health, there were only 6 in 2001, but this grew to about 78 in 2008. And by 2017, there were 26 programs, Masters of Public Health programs in the US, with a global health focus. But to be honest, I find it difficult to see how this might be sustained going forward, given the likely trends in development assistance. And I'm more interested to see what's going on overseas in terms of development of capacity for public health training. So this next slide reflects some of the growth of public health education programs in low and middle income countries. And it was really put together just by talking to some of my colleagues working at the University of Cape Town, Makerere University, the American University of Beirut, and also Prince Mahidol University. And I think it's clear when you look across this that they're all quite long-established programs. Most are competitively priced, particularly when you compare some of these programs to those that are on offer here in the US. And all of these target, at a minimum, regional and sometimes global audiences. I should also note that none of these bill themselves as global health MPHs, but because of their location and the kind of audiences that they are seeking to attract, all of them have a very strongly international flavor. And as a sort of an aside here, I think that that really sort of brings into question the utility of this term global health. It's very much an American construct in some ways, or at least a rich country construct. When I was talking to colleagues at these institutions, those at the University of Cape Town and the American University of Beirut both noted their intentions to gradually expand their programs. And the University of Cape Town noted that its current admission rate is just 1 in 20, which I think would suggest that they have substantial scope for growth if they are able to put that together. And more recently, I've been working with the American University of Beirut to help them think through their doctoral programs. Up until now, they've only offered master's programs. They've just recently launched a PhD in epidemiology. They're looking at launching a doctorate in public health, as well as a doctorate in health policy. So I think that whilst this slide is focused on growth in master's programs, it seems to me that we'll also be beginning to see that in doctoral programs going forward. So it seems that there's substantial scope for growth across these kinds of institutions, both in terms of the training and the research that they do. And from a developmental perspective, I think that this can only be seen as an entirely positive thing. But it does raise some critical questions about our role sitting here within the US context as global health experts trained in the North and working primarily in the North and residing in the North. So I've set out, I guess, a somewhat sort of scattered set of observations around these three different domains, around sort of growing inequities, around the changing face of development assistance for health, and then finally what I see going on in terms of educational offerings in global health. And what I want to try and do, and this is not entirely straightforward in the last sort of part of my presentation, is try and pull this together to think through the implications. And again, I'm thinking about this primarily for an audience of educators, but also students. I think that for those of you who are in the room who are students and who are thinking about your future in the field, this is perhaps really worth reflecting on some of these points. So I'm going to try and identify 7 different themes that I want to talk about in terms of the implications from what I've said so far. And first, and at the very core of this discussion, is the fact that we need to be able to operate effectively in an increasingly complex environment with increasingly differentiated funders and also with diverse target populations that we're trying to reach and rapid cycles of evolution. I think it's true across all sectors. Things are just changing so rapidly on the ground that, you know, a program or a model that worked a few years ago may no longer be effective. I'm not sure if you can see the small text up in the boxes here, but let me try and talk you through the different points that I wanted to make here. I think in terms of coping with complexity, there's a very well-established literature about how to strengthen organizations to cope with complexity. And reflecting on the relevance of this to the field of global health, I would argue that firstly, we need to be clear about our core priorities, our values, and our ways of doing business. And I think there's actually substantial debate within the field about what are our core values, how much does inclusivity matter, how much does diversity matter, how much does growth in the South and capacity building in the South matter vis-a-vis sort of more technological institutions and developments within the North. Secondly, I think it's critical that the field embraces learning, perhaps becoming more open to critical reflection and adaptation. I've spent a number of years working for consulting firms in the DC area, working on large USAID projects, and I think that there's some parts of the global health community where we are insufficiently reflective of the kind of work that we're doing and the value that it's really adding. And I think sometimes we've been so concerned about, you know, defending and being able to support the budgets being allocated to global health that we have perhaps not been as open to criticism as we should have been. Thirdly, I think we really need to think more about distributed leadership with people in all geographies and at all levels of the system empowered to be leaders in their own context. You know, one of the sort of core principles about coping with complexity is that you need leadership at all levels to be able to respond to challenges as they arise, as programs or policies get rolled out in different contexts. I continue to think that there's a little bit of a big man complex in global health, and I think that the more that we can break that down, and I'm seeing really encouraging signs of that. Some of you, there was a very recent launch of Women in Global Health in the Lancet, and I think that we need to have more of this discussion and more pressure to make sure that we really are a truly diverse and inclusive community. The second implication that I wanted to consider, let me go back. I've termed it around breaking north-south boundaries, but I really wanted to reflect on how our notions of what a developing country is have changed, and the presence of poverty and ill health is now widespread, both at home as well as overseas. And I think we need to be more creative about how we take lessons from low and middle income countries to inform strategies that we pursue here in the US and in Europe and other high income countries. You know, particularly in fields or the kind of strategies that global health has used, such as around community health workers, the good practices in terms of employing community health workers, whether, you know, the importance of supervision, the importance of career paths, all of these seem to me to be things that I think have relevance and can resonate in high-income countries. But I also think the reverse side of the coin is true, that we need to avoid siloing global health as public health for low-income countries. And I do think that there's some danger of that. Reflecting upon my own institution, we have a Department of International Health, which I fear increasingly is seen by other departments within the school as the department that handles lower income countries. But in terms of my interactions with students, what I find more and more is that students want to understand the models of health systems and how they've been developed in the US, but also how they've worked in Europe, what Thailand has done, the kind of struggles that South Africa is having around its health insurance programs. So I really think that we need to be much more open to learning both from high-income countries across the globe to the south and vice versa. Third, if I can get there, navigating new funding opportunities. I've talked about the changing funding opportunities for global health, but I've really not seen strong analytical work that puts all of this together, that tries to understand what's happening in terms of shifts in development assistance funding for health, what's happening in terms of corporate social responsibility, private sector funding, as well as the rise of the non-traditional sort of bilateral donors. But I think that it's imperative that we have a much stronger understanding of these emerging funding environment, and equally importantly, that we begin to think more carefully about how do we engage with that environment and what are the ethical rules that can help us navigate that environment. There's a number of recent situations which I've personally been in where I've kind of questioned, is this something we should be doing, something we shouldn't be doing? How do we make sure that this, which may be coming, this initiative that may be coming from a very positive place, but is perhaps misguided in some sense? So how do we navigate all of those? Fourth, in terms of embracing global health in all sectors, while I've suggested that perhaps global health as a field or a domain in its own right, which has been a sort of substantial recipient of development assistance, is faltering, I really don't think it's the case that global health and the global health challenges that we face are becoming less important. Quite the contrary. By WHO's own count, and I admit that WHO, the World Health Organization, is probably a little bit of a biased observer here, but they count that 27 of the SDG targets outside of the health target are health relevant. So if you look across the Sustainable Development Goals, there are targets there about reducing violence against women, about ensuring the safety of water supply, about ensuring that our roads and our transport systems are safe. So I really think that this is going to be at the forefront of the global health agenda over the next 10, 15 years. And as I'll talk a little bit more about, I'm not sure that people working in the health sector always have the skills to be able to engage effectively with those other sectors. And I think that we've sometimes neglected our role as kind of supporting actors to those other sectors. But increasingly, I think that health improvements, whether we're talking about obesity or zoonotic disease outbreaks, are going to be achieved by working in very close collaboration and partnership with other sectors. My fifth point around avoiding a magic bullet mentality, is the way I've described it, is perhaps not so obvious from what I have said so far. But I've been struck by some of the observation in Tom Bollock's recent book on plagues and the paradox of progress, which I would recommend to you if you haven't looked at it yet. He comments on how the global health imperative to save lives quickly, which I think that the spotlight of such a strong focus on development assistance for health has really sort of compelled us to think about short-term wins over longer-term gains, has often led to magic bullet approaches. And I think that we're all aware of this, and certainly as someone who's worked on health systems all of my career, thinking about how do we strengthen the broader health system rather than the magic bullets that go into that health system, I've been very aware of that. But I think Bollock argues very persuasively that in many low and middle income countries, they have perhaps leapfrogged or over fundamentally needed institutional and governance reforms by technological innovation, and yet the returns to that technological innovation may be running out. It's going to be difficult to sustain them going forward, at least. And particularly with the rise of non-communicable diseases, much more complex conditions, which are perhaps less easily solved through technological innovation, we really need to return to sort of some of the basics of development and about ensuring that we have strong governance institutions in health. Sixth, and this is reflecting perhaps on some of the comments that I made closer to the end of this presentation. The world of global health throughout my career has been characterized by some rather uncomfortable power dynamics between northern and southern institutions, with northern institutions often holding the big research grants, the access to wealthy endowments, etc. And I think that this is changing. I think, the increasing wealth in middle-income countries, the increasing desire, and I think it's really a good practice for funders to put funding through low and middle-income country institutions itself, is really changing the dynamics between northern and southern partners, and I think it's a really very positive implication. But it does mean that institutions such as Georgetown and Hopkins, and even as individuals, how we go about our work in this space is really going to have to change going forward. I think that there's much more that we can and should be doing to support faculty development amongst our low and middle income country partners, to support their innovation in new academic programs, and to be better research partners in terms of how we interact with them. So last but not least, the changes that I have outlined here signal a different way of doing business in global health. And I'm concerned that we need to reflect on what we perceive to be the core competencies of global health and ensure that they really are fit to purpose and that we're training our students to have the right skill sets to take global health forward into this new era. Clearly, some of the good old technical skills, the biostats, the epidemiology, the health policy, they're not going to go away. But I do think that we also need to make sure that we are equipping the public health and the global health workforce of the future with sufficient training in ethics, sufficient training in communications and how they work across cultural differences, as well as advocacy, so that they are effective in terms of reaching across sectors and their ability to develop effective partnerships with institutions in low and middle income countries, as well as practice and program-oriented institutions. So I started out today by saying that this talk was part of my sense-making effort. I'm sure that little of what I've said to you is entirely new. I suspect that much of it is quite familiar and probably things that you've been reflecting on and also questioning yourself. And I'm hoping that in the discussion that we can get to some of your perspectives on that. I'm hoping that at least this talk has sort of provided a space for you to reflect a little bit about these themes and issues. And I do think that we are at a watershed in terms of global health. I'm relatively positive, however, about what this might mean for the future of global health. I think that it gives us an opportunity to address some of the inconsistencies and imbalances that have existed within the global health field to date. So thank you all very much indeed for your time. And this last slide was just a shout out to some of my mentors, friends, colleagues, and it's gone, and former students who I've learned so much from over the years. I'd love to open the floor to comments and questions. And
well, first of all, thank you very much for being here. It's really a pleasure to have you and get these reflections. As someone who worked at the World Bank for about 15 years on institutional and governance issues, as you say, there's a lot about the experience that you've had in this field that rings true and familiar to people who've been working on this for some time. But I really wanted to ask a question related to, I think, the changing funding landscape that you described, but actually kind of push it even a bit further than you have. I mean, one of the most interesting things that you've described is that we made tremendous progress on sort of core indicators that there's a group of countries that have still been very much left out of that progress, and populations within those countries that have been left out. But as the funding sources have changed, they have demanded, especially from the private sector, the philanthropic side, but also because of taxpayer and public health, funding, they want results for their dollars, and they want the best results they possibly can.
Yeah.
So they've actually introduced, and I'd be curious of your thoughts about this, the whole mania for randomized controlled trials that come from, the health field, but have been now expanded to all development projects. Giving donors a sense that we want to get the biggest bang for the buck, if you will. And yet, the places they should be working, and the problems they should be working on, and the communities they should be working on, are, given the progress that has been made, if it's the last mile, if you will, the toughest environments, with the weakest governance environment, with the most corruption, the least likelihood of achieving significant results, especially the kind of results that you get from this results mania that is based on these kinds of trials. You kind of wish that there was a little bit more looseness of saying, we're going to be working these really, really tough environments. We don't know what's going to work. There's going to be a hell of a lot of expectation. We're going to fail a lot. But if we're not working on them, who else is? Because that's where the problems are. So I'm wondering how you kind of think about how you move the communities away, especially given the change in the funding environments and the change in the actors and the change in the public's appetite for aid, as you showed. How you move them and get them to accept the fact that the aid that we're going to see over the next 10, 20 years has to be the ones in the worst environments and probably going to get the least results, but someone's got to be there working on them. I wonder what your thoughts are and how you kind of make that shift.
Yeah. Can I answer that one, because it was a substantive question, and I also need a pen for the next one so that I can remember it. I think that's a great question, and I would agree entirely with your observations. And I think that there's a number of problems associated with the RCT mania, and I do feel that the health sector is kind of guilty for having dispersed this kind of methodology across different sectors, and it's become very popular. It works pretty well if you're looking at a drug in a population, but if you're looking at much more complex interventions, which I think nearly all of the needed development assistance interventions, whether we're talking about health or education, are not like a single pill, or they're typically complex packages of interventions. And so, in my view, the focus upon randomized control trials is very misplaced, because an intervention, a complex package of interventions that may work well in one space is unlikely to work very well in other spaces. I'm not sure how many of you were following the debate that's been going on about the impact of greater community mobilization in Uganda on child health outcomes, and a realization that actually a trial that had previously showed, I can't remember, but like a 7% reduction in child health due to this community-based intervention was actually built upon problematic data and was not replicable. So I think there's a problem that the aid community has driven by focusing upon results, and I think we've often misplaced the kind of analyses that we were doing. But I would argue that in terms of the popular imagination, at least, I don't think that the general public in the US or the general public in the UK are interested in the results of randomized control trials. I think that there is much more about the stories of development that we can engage them through, and is a more effective way of telling the stories of the kind of work that really needs to be done in those kind of contexts. And I've noticed a lot of differences across different development funders in terms of their appetite for risk. And I really don't understand quite, why that is the case. So, for example, we've had some big grants from the Department for International Development, and they've encouraged us to take risks. I mean, to take calculated risks, and we have to complete, risk matrices that spell out exactly what the risks are in terms of the work that we're trying to do. But I'm not quite sure how we can encourage other funders to be more be greater risk lovers, essentially. But I think that as you describe it, the focus not just upon RCTs, but counting the nuts and bolts of, how many vaccines were delivered, or it is really often missing the point of what's required for development in the communities we wish to work in. Other comments and questions? Yes.
You mentioned briefly the need for increased institutional capacity, and my impression is that this is a subject that aid agencies have, and the other funders you're describing, have avoided for a long time. And in fact, many of the initiatives, the new initiatives that you're describing, seem to be more vertical and technology-oriented than developing broad capacity. And there's similar phenomena in agriculture, where there's been a lot more research on particular crops and a lot less intervention in developing the comparable broad gauge capacity. And my impression also is that the problem is the lack of political saleability of these horizontal programs, both in the donor community and in the countries themselves. The donors want something where they can manage it easily, they can control it, and they want something they can measure the results, and there's all kinds of stuff going on in developing countries. Conversely, the places where there seem to be results in the institution building arena are places where the initiatives come from the country themselves. And in some of these countries are pretty unlikely. I mean, I heard a program in Pakistan was doing fine. So my question is whether what your thoughts are on the saleability of these programs. I think my impression is that the profession is coming to the conclusion that that's where the job is: governance, organization, all the stuff that you've been studying for your whole career. But how do you sell that?
Yeah, no, I think it's a great question, and I would agree with you that we haven't done a good job selling it. And I think that in part it's because of the sort of short-term cycles of development assistance in virtually all of the development partners that I'm aware of. It's very rare that you get donors or development partners who are willing to commit to 5, 10, 15-year cycles. I mean, I think some of that has been done within the health sector. I think that Swedish CEDA has been quite remarkable in terms of some of the long-term commitments that it has made to capacity development. In terms of how you sell it, so I'm getting lots of questions about how do you sell these good ideas, or how do you sell the things that we really want to work on when there are so many forces against it. So I guess, when I talk about capacity development, I'm thinking about capacity development in terms of organizations as well as in terms of individuals. But again, I think it's often stories that make this much more powerful to people. So being able to show the kind of individuals who've benefited from training and the really remarkable work that they've been able to go off and do. There are good stories about more broad institutional change. So, for example, in the health sector, the Thai government invested over a period of about 20 years in really building very significant individual capacity and institutional capacity to manage the health sector. And as a consequence, I think there's been very many, truly remarkable achievements that they've managed to make, from, developing universal health coverage on the one hand to addressing some of the sort of NCD risks on the other. So I think we need to tell those stories more and more effectively. And I'm sorry I haven't got better solutions for that. I'm wondering if it would help to take several questions at one time so that we can maybe get more of a dialogue going between you rather than me talking so much. So yes. I'm sorry I don't know your names, I'm just pointing.
So I'm actually not like a STEA major, but but I am studying like international political economy, so this does, I think, have a relevance. And I'm just kind of wondering if, like, you think that global racism has an impact on like developmental aid policies, specifically given by the West, and like how we can combat those types of biases.
Do you have more of a hypothesis there about how, if there are particular channels through which you're thinking that it does affect it? I have some ideas, but I'd be interested in yours.
I'm like not entirely sure, but there have been like, I guess I've read articles where people have made the conjecture that a lot of like development, like aid that's been given in like Africa has not been useful, and like there have been suggestions that there has been impacts of like racism playing into that, specifically by not being in touch with like the cultures within African countries or with like stereotyping. So I'm just wondering, like I'm not like too educated on the idea, but which is why I just want to know if you think that plays a role.
Okay, great. Is it okay if we take a few questions and then I'll try and do my best to address them.
Thank you so much for your presentation. I'm a former SFS graduate, and I worked actually with Global Fund for tuberculosis in Pakistan for a couple of years, and now doing my PhD. So all the points that you raised, they struck a chord. So I just wanted to ask a couple of things. So we already spoke that RCTs might not be the most, best way to raise the interest of countries who are donors, and to raise interest in doing more of the official assistance. You also see that the RCTs don't seem to excite the receiving countries as well. For example, if you go and talk to a policy maker, they're rarely concerned about which intervention is the most efficient one. That they just want it to be the most visible one, and the one that keeps the money coming in, so that they can just keep doing the work over and over again. Secondly, we were talking about the changing nature of funding, and we all recognize that the official development assistance, in addition to the funding from, let's say, the Global Fund, was very tenuous, and secondly, it came with strings attached. So, for example, during my work, we were expected to produce results out of thin air. All this money was being pumped into the system by the Global Fund, and there was just not enough institutional capacity to produce the results that were expected of Global Fund. So, how does the funding respond to such institutional constraints? And finally, I just wanted to say that when we talk about global health systems, we see the political economy side from here, from the US or from the global north, but there's a big political economy aspect in the receiving countries as well. In some ways, this funding is seen as foreign, and as you might be seeing with all the nationalistic sentiments cropping up all over the world, this might not be welcome in a certain context. So if you could just speak a bit to that would be awesome.
Yeah,
Thank you.
Great. Thank you very much. Good questions.
Hi, my name is Kelly. I'm a senior STEA major. My question will be relatively simple compared to the ones that have been before, but I was just wondering what, in the path that you've laid out for global health, what you see as the role of international global health institutions, and what role global governance will play, such as the WHO, whether it'll be just like coordination or more direct involvement.
Great, thank you.
Hi, my name is Sanjay. I'm a second-year student in the graduate program for foreign service. My question is, so it seems like humanitarian and development work are increasingly overlapping. And as environments like DRC or Yemen or South Sudan wind up being these places for humanitarian healthcare, what is the path forward for health system strengthening in these environments, I guess at a local and national level? Thank you.
Great, thank you.
Hi, I just wanted to ask on the issue of global health education. I'm picking on some of your thoughts. What I've observed working in the South is there's a growing trend, yes, to build capacity, but rather to train scientists in the South, and less, what was happening traditionally about maybe going to institutions in the North. What I wanted to know was your thoughts around, first of all, retaining scientists, whether if they've trained at a northern institution. Secondly, on this issue of capacity at the southern institutions, if more of the scientists will be trained there, and if you are training more scientists in the South, will they be as competitive on a global scale if they're trying to do meaningful work in global health?
All great questions. So I'll have a bash at them. I'm not sure that I'm going to be able to do a brilliant job on all of them because they're often quite tough questions. But the first question was about global racism and about stereotypes and whether that may affect aid. I'm really not sure that I am in a good position to talk about that. I guess one thing that I have been concerned about is, and I talked a little bit about this in the presentation, is around I think that there's a difference between the rhetoric of global health about being inclusive and diverse and what we actually see playing out in terms of the people who get invited to participate in the big meetings, the people who get invited to lead the Lancet series on global health. So I'm not sure if that is racism. I think sometimes there's a perception that credibility and legitimacy comes from aligning yourselves with well-known institutions, whether it's Georgetown or Oxford or wherever. But I think that overlooks the fact that, all of the literature says that we really need to have those voices at the table, and it's the perspectives of the people who are trying to solve the problems on the ground that is really going to be most relevant. So that's a little bit different from, maybe it's racism in some form, but I'm not sure it's getting exactly at what you were asking, but it's a perception which I think links to what you were asking. So you had a number of questions. I can't quite see where you've gone about the fact that RCTs don't excite the receiving country. Absolutely. I think that, by and large, countries, when you're talking to them about pilots or research, would much prefer that we were rolling out policy development. And your second observation that development assistance often comes with strict reporting requirements, you need to do this, do that, and yet often there's just a fundamental lack of institutional capacity in country. I think that's actually quite a profound observation, and I say that from a couple of perspectives. I've seen it play out time and time again. When I've lived overseas, I've noticed that the people coming in and designing some of these programs, so they're often designed by people flying in, spending some time there, flying out again. They meet with people at the top level. They meet with the people who've got their PhDs from Georgetown or Hopkins or whatever. And so I suspect that sometimes they walk away with a very artificial sense of what the true capacity is within that context. And it's only when you're spending much longer period kind of delving down to the system, because it's not the handful of people who sit at the top of the ministry who are going to actually implement this stuff. It's the people, spread throughout the districts, the provinces, wherever. And often at that level, as you say, the capacity simply doesn't exist. But I think the other thing that's going on there is that there's entities like the Global Fund, you're obviously competing in some sense for the resources that become available. And I know this from the kind of, when we're submitting research grant applications, we're often over-promising in order to be successful in terms of securing the funds. And then there's really not aligned with what we're able to deliver after that. And your observation about the political economy and how governments perceive this development assistance, I think is also something which is really interesting, and it would be great to have more research that really understands those perceptions. I had that one quote from the former finance minister in India, but I see that time and time again. And I think, and again, in some ways, that also means that there may be scope for more productive discussions if development assistance becomes a smaller part of the picture in health funding. Kelly, what's the role for international global health institutions going forward? And you kind of framed this as, this is just a small little question, so it's actually a really tricky one. So, I mean, I guess WHO is perhaps the most immediate and obvious institution to look at in this regard. And honestly, I see some, I was going to say signs of improvement with TEDRAS. I mean, there's also a lot of problems there, but I do think that some of these dynamics about how higher income and lower middle income country institutions work together, really thinking about diversity in terms of staff working within the institution. I think that TEDRAS, and also actually, I think TEDRAS has also been very good in terms of advocacy and articulating a role for the institution. So I'm beginning to see that particular entity evolve and respond. I think that their core mandate, which is actually about sort of largely around developing norms and guidelines, and for WHO not about delivering development assistance programs, is going to continue to be absolutely critical going forward. So, but I would observe that, over the past 20 years, the space that WHO has been working in has just become more and more crowded, and it's become harder and harder for them to really exercise an effective leadership role. And I have got to the point where I'm not sure that that's ever going to be the case again, but there certainly is a need for that kind of institution. And Sanjay, your comment about, how do we strengthen health systems, recognizing that more and more of the sort of development assistance, I'm sort of looking around the room again, oh, thank you, more and more of the work that we might do with support from development assistance is going to be in challenging environments, and what are the kind of approaches for health system strengthening within those environments. I mean, I think that that's perhaps a different and longer discussion, but I do think that firstly, some of the points that I've made about, essentially thinking long-term, and thinking about how do we build capacity, how do we build legitimacy, how do we build governance are all really important in those kind of settings. And I think that very often the development partners working in Afghanistan or other places have often looked to sort of models that contract out basic service delivery to non-governmental organizations. And I think that whilst that can be helpful in terms of scaling up services and health services in particular relatively rapidly, it's also problematic in terms of that building of legitimacy and trust in government over time. So I think that needs to be unraveled and thought through a little bit more. I think we're...
I'm actually going to throw one more question at you before I say thank you for this wonderful lecture. I know we've all enjoyed it. Thank you, everyone who stayed to the end. I wonder if you might end with some sage advice to eager young global health students thinking about a career in global health.
So I get lots of students coming to me and sort of saying, where do I go with my career, and what would you advise about X, Y, and Z? And one piece of advice that I give is just go and spend time in the field. I think that there are far too many people working in global health who really have done, 2-week trips and little more. And I think that without spending extended periods of time working in the countries that you're and with the people that you're trying to serve, you're missing 95% of what's going on. And I think that lack of understanding then manifests itself in some of the challenges that we've been talking about today. So that would be, there's a whole lot of other things that I could say, but that would be my number one thing. Spend an extended period of time on the ground, getting your hands dirty, and really understanding the nuances of the challenges that these countries, the countries that we work with, are facing. Thank you very much indeed. It's been a real pleasure, and you've been a fantastic audience, so thank you.